Dr. Ken Landau. Thanks for watching. Let's talk about Prolia, also known as Xgeva or denosumab. It's a treatment for osteoporosis. What is osteoporosis? Osteoporosis is a risk factor. It's not a disease. It's a risk factor, just like having high blood pressure, high cholesterol is a risk factor for having a heart attack. Well, having a low bone mineral density, which is osteoporosis, is a risk factor for having a fracture. We want to prevent the fracture. We don't really care about the osteoporosis. It's a fracture we want to avoid. And this drug does a pretty good job of it. It was approved in 2010, principally to treat osteoporosis in women. It's a much more common condition in women than it is in men, and it tends to occur in people over 65 rather than under. The drug was approved for women with osteoporosis, and then it was found that it might actually prevent problems with the bone in people who had tumors metastatic to the bone, say from breast cancer or from prostate cancer that would otherwise cause a fracture of the bone. Well, this seems to be a good treatment. Additionally, the drug company said, it looks like this drug may well prevent some of the breakdown of the bone that comes along with treatment of steroids. So people who are taking prednisone, people who are taking cortisone therapy, maybe for rheumatoid arthritis, maybe for transplant, maybe for some other kind of condition. Well, those individuals are at high risk for developing significant osteoporosis within the first 3 months of therapy. And those people can be improved by treatment with Prolia. And the Food and Drug Administration is currently evaluating that, probably is going to say yes. Well, the risk of osteoporosis and fracture isn't equivalent throughout society. So there are certain people who seem to be at higher risk. And Caucasian women are at higher risk than Hispanics and Asians, and they're at higher risk than African American women. And depending on where in the world you are, the risk varies. So in the United States, if we look at the 10-year probability of a person having a fracture, a person who's otherwise normal weight, doesn't have any special risk factors, still has about a 13% chance of an osteoporotic fracture, as opposed to, say, in Sweden, it's only 10%, as opposed to Japan, it's 8%, as opposed to China and Spain, where it's 3 or 4%. And in Turkey, it's less than 2%. Well, there are certain risk factors that you can have that predispose to osteoporotic fractures. So if you have a tendency to fall, if you've lost height, the reason you lose height is because your backbone collapses, your vertebrae collapses, and that's typically osteoporotic. If your mother has a history of osteoporotic fracture, you're at greater risk if you're not getting enough calcium in, or if you have the inability to get out of a chair without assistance, you're probably going to fall. And it seems like it's the fall that causes the fracture. You can have osteoporosis for a long time and have zero symptoms, just like you can have high blood pressure for a long time and have zero symptoms from the cardiovascular standpoint. But then something tips the scales, and then you have a heart attack, or then you have a fracture. And as far as fractures are concerned, for the most part, it's a fall, except for your backbone. It could be simply the fact you stand up or you twist wrong. And when we look at the bones themselves, there are different kinds of bones. There's what we call a cortical bone and what we call a trabecular bone. The cortical bone would be the bone in your leg, the femur. Big, thick bone, but it can have some porosity. That puts it at increased risk. And we know that the trabecular bone, the bone of your spine, your vertebrae, well, it all depends on how many little spicules they have and whether they're connected or not. Those are very important factors in determining whether you're going to be at risk. And as a matter of fact, about a third of the osteoporotic fractures are diagnosed, and 2/3 of them aren't even diagnosed, because you can fracture your vertebrae, you can have vertebral collapse, have no symptoms. That's very common. And as a matter of fact, about half of all of the fractures that we say are osteoporotic have nothing to do with osteoporosis. And you can even develop osteoporosis as a secondary condition because you have type 1 diabetes, or maybe because you have hyperthyroidism, or maybe because you have a liver disease, or maybe because you have celiac disease, or you're taking steroids like I mentioned before, or you have rheumatoid arthritis or lupus. Or you're taking a medicine for seizures, maybe like Tegretol or valproic acid. So how do we determine who's at risk? Well, typically, the older you are, the greater your risk. The thinner you are, the greater your risk. But we can use something known as the FRAX calculator, F-R-A-X calculator. And you can access this anywhere online. You just go to Google and you type in FRAX risk estimate or FRAX calculator. Go to National Osteoporosis Foundation. They'll give it to you. University of Sheffield is where it was developed over in Britain. So go to University of Sheffield and come up with a FRAX scale. And all you have to do is you input your age and your height, your sex, your weight, whether you have a previous history of a non-traumatic fracture after you were age 50, whether your parents had a fracture, whether you're a smoker, how much do you drink, do you take steroids, do you have rheumatoid arthritis, and then you should put in your bone mineral density. Bone mineral density, you got to go to the doctor and have that put in. Now you can do the calculation without the bone mineral density, but it won't be quite as accurate. So it's important. What you can do is use that calculator, and then we determine whether you need treatment. Now certainly, if you already have a history of a fracture, either your hip or your vertebrae, yeah, you need therapy. That's a no-brainer. On the other hand, if you have a very low T-score, most people would say you need therapy. Low T-score is when the T-score is more than 2.5 standard deviations below normal. Now, if you're over age 50 and you're sort of in the gray zone between the level for osteoporosis and the level for normal, you're in that in-between. We call that osteopenia. But on calculation, you have a 10-year risk of 20% or more for an osteoporotic fracture, or 3% for a hip fracture, then you need therapy. But remember, if you're in the gray zone, in that osteopenia zone, you don't need therapy unless, on that calculation, you are at risk. Now, the calculation, this T-score and the standard deviations, is all based on a Caucasian woman between the ages of 20 and 29. And of course, if you're 65 or 70, your bones are not going to be like those of a 20 or 25-year-old. Neither is your skin, neither is your heart, neither are your lungs, neither are your muscles. So that makes sense. Now, as you get older, even if you don't have any significant risk, just age itself is a major factor. So let's take the average 10-year risk of a hip fracture in a man and a woman. In the man, age 60, it's going to be 1.5% over 10 years, woman 2.5% over 10 years. So that's the risk. If that person is 10 years older, now age 70, if you're a man, the risk isn't 1.5%, the risk goes up to 6%. For 10 years. If you're a woman, the risk isn't 2.5%, it goes up to 7.5%. So you don't have osteoporosis now, you may well develop it later, kind of like diabetes. You might not have diabetes when you're 30 or 40 or 50, but you might develop it when you're 60, and the same with osteoporosis. You don't have it, then all of a sudden you got it. Well, Prolia stops the bones from being broken down. You have to understand that the bones have two sorts of cells. One is called an osteoblast. It manufactures bone. And it has a team member called an osteoclast, and it breaks down the bone. The two work together, the two cells. There are zillions of them in the bone. And the osteoclast and the osteoblast are working in unison. Now sometimes, especially in youth, the osteoblast works harder. When it works harder, then your bones grow. So when you're born, you're teeny weeny, and then all of a sudden you're 5.5 feet, 6 feet tall. The reason is because the osteoblasts are working harder than the osteoclasts, but both of them are working all of the time, basically. Now, as you get older, say 30, 40 years of age, they're sort of working in unison. Neither is outdoing the other. Unfortunately, as you get beyond about age 35 or 40, the osteoblast gets a little tired and it takes a rest relative to the activity of the osteoclast that keeps breaking the bone down. Now, the osteoblast is manufacturing the bone, but not as rapidly. That's where Prolia comes in. Prolia works because it prevents those osteoclasts from breaking down the bone. And it prevents them from breaking down the bone both in the cortical bone and in the trabecular bone. And it works relatively quickly. It works much more rapidly as far as the osteoclasts are concerned. So it stops the breakdown of the bone very quickly. It takes a little while longer for it to start stimulating the growth of bone. And the way it works is unique. It's considerably different. It's totally different than what we call bisphosphonates. That's Fosamax, the Actonel, the Boniva. This one is a different class. It's a class all by itself. And what it does, it inhibits a chemical the body makes called rankle. R-A-N-K-L, rankle. Now, rankle is a substance that goes over to the osteoclast and stimulates it. So stimulates it to break bone down. What the Prolia does, it's a monoclonal antibody, so it locks to and prevents the rankle from getting to the osteoclast to turn it on. So it's sort of in an off position, and that's very good. Now, this rankle substance is manufactured by the bone marrow stromal cells, by the osteoblasts, some of those cells that are making the bone, and by the T cells, that's the type of white blood cell in the body. And it's very important to have this substance active in order to break down the bone. Well, if we look at the trabecular bone, that's the vertebrae basically, fractured more than any other bone in the body. So the vertebrae are extraordinarily sensitive to the osteoporotic fracture. And with treatment, we can reduce the likelihood of a fracture of the vertebrae quite considerably, probably by 50%. And that's significant. But for the overwhelming majority of people, as I said, most of the osteoporotic fracture is not even noticed. So we care what's happening in the vertebrae, but we're more interested in what's happening in the hip. The hip is very important because if you break your hip, that's going to significantly incapacitate you. And the hip or the femoral neck, fractures, fortunately, much less frequent, but unfortunately the benefit is somewhat smaller. Now, as far as making bone thicker, all of these medicines in the osteoporosis treating family work. So the Prolia works and the bisphosphonates work. It doesn't matter which one you take, basically, whether it's the Fosamax or the Boniva or the Actonel. They have some others. Or another one called Forteo. They all work, but they work a little bit differently and they work at different rates. And what we know is that thickening of the bone by itself, increasing your bone mineral density, does not directly correlate with your being at lower risk for a fracture. Because it all depends on the anatomy, what's really happening inside the bone. It's not just the thickness of the bone, it's how is the bone architecturally. That is even more important. So, one study showed recently, 2017 study, that Prolia really didn't benefit men, even though other studies show it did. Postmenopausal women, it will decrease the risk of fracture. Yes, indeed it does. But those chemicals, that rankle I was talking to you about, that's manufactured by the white cells and the osteoblasts and the bone marrow stromal cells, it's doing other things in the body. And if we stop those things from working, unfortunately, that increases the risk of infection. So then we have to decide, is the risk of infection or the risk of the osteoporosis more important? Well, the good news is that it works very well, especially in the cancer patients, and it probably works better than any of the other kind of therapies we have if you happen to have cancer. We know that your bone mineral density increases substantially. Let's say we're talking about an osteoporotic woman. If we follow her for a while, over a period of 3 years, The bone mineral density in the lumbar spine is going to increase by about 9%. In the hip, it's going to increase by about 6%. The femoral neck, it's going to increase by about 5%. But that doesn't directly correlate, as I said, with a reduction in the fracture incidence. So if we look at the vertebrae, we compare the Prolia group to the placebo group, well, we're going to have an absolute difference in the fracture rate of about 5%. The company will say the relative rate is almost 70%, but it's really the placebo group has 7.5% fracture rate. The Prolia group has about 2.5% fracture rate. That's where the difference is. On the hip, however, you don't usually get the hip fracture, so you have to treat an awful lot of people to benefit the hip. So in the placebo group, slightly over 1% of the people are going to suffer a hip fracture in the study, versus the Prolia group, about 0.75%. So the difference is only 0.3% to 0.5%, somewhere in that category. The drug company will come up with a number that it's really a 40% reduction. That's a relative. The absolute is only about 0.5% or less. Now, interestingly, a study that was presented in the San Antonio Breast Conference showed that Prolia might help prevent cancer from appearing in the bones. There was an 18% decrease in the recurrence. That's sort of a almost statistically significant finding. That's an early finding. It's going to have to be repeated, but that was a 4-year finding. The risk of bone fractures, however, did fall by 50%. Men with prostate cancer, same sort of deal. The treatment, the Prolia, protects the bone, increases the bone mineral density, and can significantly reduce the likelihood of a fracture. Now, you can't take the drug if you don't have enough calcium floating around in your bloodstream. So you have to have calcium on a regular daily basis. You have to take your vitamin D, 1,000 milligrams calcium, 400 international units or more of vitamin D. As a matter of fact, if you have too much calcium because you have cancer in your bone and now the calcium is leaching from the bone into your bloodstream, and it's causing some problems. It can cause kidney stones, or it can cause excessive urination, or it can, unfortunately in some people, cause mental problems or obtundation, coma. Well, if the calcium's too high, we can use Prolia because it's going to help get rid of the calcium in the system very quickly. It comes in pre-filled syringes. You give yourself, or the doctor can give you, an injection either in your upper arm, in your belly, or in your thigh. 60 milligrams, one dose, one syringe. Keep it in the refrigerator. Take it out about 15, 20, 30 minutes before you use it. It's clear, colorless. Don't forget, you got to keep taking your calcium. It gets into the bloodstream in maximum quantity in about 10 days. The half-life is about 25 days, about a month, and it sort of wears out after about 4 or 5 months. People have taken it for years and years, done okay. Some side effects, sure. Everything has some side effects. Some pain right where you get the shot, and maybe some aches and pains in your muscles or your joints. The increase in risk of infection, as I mentioned, the placebo group had about a 9–10% likelihood of an infection, but in the group receiving the Prolia, it was about 15% infection, and it could be infection like cellulitis of the skin or cystitis, urinary tract infection, abdominal infection, even endocarditis is possible. And remember, that's because that rankle that's being blocked or inhibited has function other than in the bone. Well, some people get, for reasons that we don't understand, they get significant and severe back pain or extremity pain. Some people have developed constipation, and they argue whether it causes hearing loss. The Brits think it might, and the Canadians think it probably doesn't. Now, one of the problems with either the bisphosphonates, the Fosamax, Actonel, Boniva, or the Prolia, is they could cause osteonecrosis of the jaw. Osteonecrosis, the jawbone, the mandible. can just all of a sudden have part of it that becomes necrotic. It dies. That's a significant problem. And it's made worse if you happen to have any kind of dental surgery, you have a tooth pulled, might not heal well, or if you've had radiation therapy, or you're getting cortisone therapy, or you've got chemotherapy. So anybody who's taking this medicine who has any jaw numbness or pain in the jaw, redness around the tooth, perhaps loosening of a tooth, got to go see your doctor right away. And we also know that some people develop, after they've been taking the medicine for a couple years, they can develop atypical femoral fracture. So that long bone in your leg between your knee and your hip, that can break just spontaneously. And we're not exactly sure why that occurs, but most of the people are going to get some dull ache or some pain in the area. And that can be a significant problem. It can be on one side, or it could even be on both sides. Some people get allergic reactions to the medicine. Some people have low blood pressure, shortness of breath. Their skin can feel tight. They can get itchy, or they can get the hives. This drug isn't for women who are pregnant or lactating, but we're not talking about that age group unless we're talking about somebody with cancer. This is a big seller. The Prolia, they estimate that it's bringing in somewhere between $800 million and $900 million a year, and the Xgeva, that's used pretty much to prevent the cancerous problems with the bone, that brings in about $1 billion, and they expect in 2018 the two drugs by themselves going to bring in somewhere around $3.4 billion. So we're talking about big business. That's why you're deluged with ads on the television for this drug. Well, how much does it cost? Anything that's advertised a lot is going to cost a lot. So if you paid cash, you just went down to the drugstore with the prescription, say, here, fill this, I'll give you cash. $1,344 is the cash price, average. If you have a coupon that you could get from GoodRx, might fall between $1,100 and $1,200. You need 2 injections of that stuff a year. If you're taking the Xgeva, you need more, and that costs $2,200 a syringe. You can get a copay card, and that will reduce the shock. Now, the question is, how do we decide who needs what therapy? Well, it's kind of between you and your doctor. You have to remember, though, that osteoporosis is not a disease. It is a risk factor for a fracture. If you exercise, if you build up muscle, if you have something to pad the bones and pad the joints, then chances are your bones will continue to grow and strengthen. If we go back thousands and thousands of years, osteoporosis was not a problem. The bones were phenomenally thick because people did a lot of work. Nowadays, we sit on the chair and we play with the computer or play with our iPads. That's not going to build thick bone. Go out and do something. Go play ball. Go and go for a walk. Get on a treadmill. Do something. And if you do, and if you build some muscle, and if you build some bone, then this isn't going to be an issue. You're not going to have to take any of these medicines. But if you do need a medicine, depending on severity of the problem and depending on how often you're likely to take a pill versus get a shot twice a year, this certainly is a legitimate option. The question is, have we overblown the whole story of osteoporosis? And unfortunately, at the present time, I think the answer is yes. We've made it one of those things that everybody talks about, but relatively few people understand. And it's certainly one that, unfortunately, a lot of people are being treated for who probably don't need the therapy. Anyway, I'm Dr. Ken Landau. Thanks for watching.